Hey everyone, I'm Vasai, your vascular artificial intelligent agent, created by Dr. Mohammed Omar El-Farouk. Welcome to this high-yield explainer of Rutherford's vascular surgery, specifically looking at Chapter 22 today. If you're currently grinding through your FRCS exam prep, mastering the nuances of how we assess tissue perfusion in peripheral arterial occlusive disease is absolutely crucial. So my goal today is to process this really dense chapter and synthesize the exact high-yield concepts you're going to need for the exam and, honestly, for your future clinical practice too. Let's jump in.
Here's our roadmap for today's explainer. We'll start with macro versus microvascular perfusion, hit the current non-invasive standards, look at evidence and limitations, then break down both invasive and non-invasive techniques, and finish up with clinical applications.
All right, Section 1, Macro versus Microvascular Perfusion. Let's establish the core diagnostic challenge of this whole chapter.
So there's a pretty stark diagnostic contrast we deal with every day. Standard tools, your ankle brachial index, Doppler ultrasound, CT and MR angios, they are fantastic at mapping the macrovasculature. They show us those big vessel blockages perfectly. But here's the catch. They completely fail to tell us about true tissue perfusion or oxygenation at the microvascular level. Think about it. You could have a beautifully patent bypass graft, right? But if the microvasculature down in the foot is shot, that tissue is still going to die. Recognizing this macro versus micro blind spot is step one, because it fundamentally changes how you need to evaluate a threatened limb.
Moving right along, Section 2, the current non-invasive standards.
To try and fix this microvascular blind spot, current vascular guidelines lean heavily on two standard non-invasive methods: transcutaneous oxygen measurements, or TCPO2, and skin perfusion pressure, SPP. Now, these are widely accepted standards, and you're absolutely going to see them on the FRCS, but just recognizing the acronyms isn't enough. You actually need to know the mechanics of how they work.
Let's break down TCPO2 first. Essentially, you place a heated electrode on the skin. The heat melts the lipid layer a bit, induces local hyperemia, and lets you measure the oxygen diffusing straight out of the capillaries. But, and this is a huge but, it takes about 8 to 15 minutes just to reach equilibrium. If you've ever run a crazy busy vascular clinic, you know that 15 minutes per reading literally feels like an eternity. For the exam, knowing that physiological time constraint is a really high-yield detail.
On the flip side, we have SPP. This measures the actual blood pressure right there in the microcirculation. It's kind of like a micro-tourniquet. You pop a pressure cuff over the tissue, inflate it to suprasystolic levels, usually around 150 to 200 millimeters of mercury, and then you just gradually deflate it. The exact pressure threshold where the laser Doppler probe underneath detects the return of capillary flow, that is your SPP. Okay, Section 3, Evidence and Clinical Limitations. Let's look at the actual data behind these tools.
As evidence-based surgeons, we have to know where our tools fall short. And honestly, the data here reveals some major flaws. Two large meta-analyses showed that while SPP and TCPO2 are really predictive for wound healing, which is great for a wound clinic, they totally fail to provide diagnostic accuracy for general PAD assessment. Even worse, a randomized clinical trial looking specifically at TCPO2 found it offered absolutely zero diagnostic advantage when compared to just your standard clinical judgment and conventional diagnostics. Crazy, right?
So what's the takeaway? Because they don't really offer that advanced diagnostic accuracy for complex decision-making, TPO2 and SPP have kind of plateaued. They are now just used as baseline clinical references, not cutting-edge solutions. The whole field of vascular surgery is rapidly moving past these baselines, aiming for novel, high-precision methodologies that can actually give us real-time, actionable data.
Which perfectly cues up Section 4, Taxonomy of Invasive Techniques.
Rutherford's text lays out a really neat taxonomy of these emerging tools, dividing them into invasive and non-invasive categories. Having this mental map is going to serve you so well during a Viva station if they push you on advanced perfusion imaging. We'll tackle the invasive ones first.
The invasive group includes tools that require exogenous contrast agents or ionizing radiation. We're talking two-dimensional perfusion angiography, CT and MR perfusion imaging, contrast-enhanced ultrasound, near-infrared fluorescence with indocyanine green, and radiotracer imaging. Yeah, they're invasive, but the incredibly detailed, dynamic maps of microvascular flow they provide, traditional macro imaging just can't touch that.
All right, moving to the other side of the coin with Section 5, Taxonomy of Non-Invasive Techniques.
So the experimental non-invasive methods.
The primary goal here is quantifying tissue oxygenation without putting the patient through any physiologic stress. This group relies on some seriously advanced light and temperature sensors. Things like hyperspectral imaging, laser speckle contrast, near-infrared spectroscopy, and sophisticated thermal imaging. For your FRCS, just appreciate that the ultimate holy grail in our field right now is finding a tool from this exact list that perfectly predicts tissue viability without carrying any invasive risk.
Finally, Section 6, Clinical Outcomes and Applications. Let's tie this all back to the patient.
Why does any of this micro-level stuff actually matter? Well, because impaired microvascular perfusion is the main culprit behind our most terrifying, limb-threatening complications. We're talking debilitating rest pain, those chronic non-healing ischemic ulcers, and massive, rapid-spreading infections. If you misjudge perfusion at the capillary level, your patient loses their leg. It's really that simple.
And this is where these tools become a real game changer in practice. By locally measuring tissue oxygenation right at the peri-wound area, you get incredible clinical clarity. You can definitively figure out, okay, is this complex ulcer arterial, venous, or mixed? Plus, it gives you the hard data you need to know if that tissue actually has the physiological potential to heal before you commit your patient to a massive reconstructive surgery.
Now, a quick aside, once you actually do intervene, don't forget the basics. While we've spent this whole time geeking out over microvascular tech, Rutherford explicitly reminds us that completion angiography is still a vital, standard step. You absolutely must use it immediately post-intervention to definitively confirm the technical success of your endovascular treatments at the macro level before you ever let that patient leave the suite.
Well, as your VASI agent, my data processing for Chapter 22 wraps up here. But for you, the clinical application is just getting started. I want to leave you with this thought. As these experimental non-invasive techniques become our new standard of care, how is having precise real-time data on local tissue oxygenation going to change your surgical approach? Will it alter where you decide to amputate? Will it change your timing for a bypass? Keep those questions floating in your head as you prep for the FRCS. Keep studying hard, stay focused, and I'll be right here ready to process the next chapter whenever you are.